Hello, everyone. Welcome you all to this training module on CT perfusion interpretation. On behalf of the North Midlands Integrated Stroke Delivery Network, we welcome you all. My name is Indira Natarajan. I'm a clinical director for the stroke in the West Midlands Integrated Stroke Delivery Network. And I have the pleasure of my team along. I've got Dr. Maha Abdul Ghani, who's a consultant stroke physician and a colleague of me working along me in the University Hospital of North Midlands at Royal Stoke University Hospital. We've got Melanie Cassidy Lockett, who's the project lead for the North Midlands Integrated Stroke Delivery Network. So the purpose of this CTP interpretation course is we wanted to reach out to all frontline clinicians, whoever it may be, seeing patients with stroke, who's got all the imaging, and CTP is going to be included in decision making for thrombolysis, particularly extended the thrombolysis window, and also making decision on thrombectomy. So we wanted to make sure that you understand the principles of interpreting CTP, how you can use it in your practice. And we thought the best way to reach out to a lot of people is through an online module. This is a first attempt, and obviously we would welcome your feedback to see how we can improve this over a period of time. And hope you enjoy and it is of educational value to whoever is watching this. Thank you very much. Hello, everyone. My name is Dr. Indira Natarajan. I'm a consultant stroke physician based at University Hospital of North Midlands at Royal Stoke University Hospital. The first part of the presentation, I'm just going to take you through the national stroke guidelines and some basic information about CTP. So the National Clinical Guidelines for Stroke, which was published in 2023, has given us some guidance on the thrombolysis window and what are the imaging that we need to use on decision on thrombolysis. The eligibility criteria for extending the thrombolysis to 4.5 to 9 hours and wake-up stroke was the new thing that was introduced in the stroke guidelines in 2023. So this slide shows us the three categories of patients coming into our front door. So the top one is the wake-up stroke, when patients are presenting beyond 4.5 hours from the last seen well, irrespective of the upper limit. The imaging criteria is we need to just use the MRI DWI flare mismatch to make a decision on lysis. So if there is a mismatch, if there is a DWI lesion and no flare lesion, then that's a patient where we can thrombolyze. So the second part is the wake-up stroke or unknown onset time, or whether we have a known onset time. So in all these situations, we can use the CTP criteria for making a decision on thrombolysis. When it is a wake-up stroke, we have to calculate the time from the midpoint of sleep up to 9 hours. And if that is matching with the CTP criteria for thrombolysis, then we go ahead and thrombolyze the patient. And again, with known onset time, if it is 4.5 to 9 hours, we can use the CTP criteria to make a decision on thrombolysis. And the CTP criteria is three components. If they have a mismatch ratio of greater than 1.2, a mismatch volume of greater than 10 mils, and an ischemic core of less than 70 mils. And we'll be taking you through all this when we are looking at the CTP images. Now we are moving on to the thrombectomy guidelines. So anterior circulation stroke with proximal large vessel occlusion. So within 6 hours, patients having a Rankin scale of 0 to 2 with an NIHSS score of 6 or more than 6. There's no specific imaging criteria. We can take the patient for thrombectomy. If the patient is between 6 to 12 hours with a Rankin of 0 to 1 and an NIHSS score of 6 and above, if the patient has got an aspect score of 3 or above, irrespective of the core of infarct size, we are going to take the patient for thrombectomy. If the patient is between 12 to 24 hours of wake-up stroke, and if the Rankin is 0 to 1 and the NIHSS score of 6 or more, then we go into the CTP perfusion criteria, where the aspect score is greater than 3 and the CT be mismatch of greater than 15 mils, irrespective of the core infarct size. All these are criteria for taking a patient for thrombectomy from a comprehensive stroke unit. Posterior circulation stroke with intracranial vertebral or basilar artery occlusion. Again, the guidelines says that we need to be taking patients only within 12 hours with no clear guidance of Rankin. The NIHS score is 10 or above, and a favorable PC aspect score and a Pons midbrain index. Caution should be exercised when considering mechanical thrombectomy for patients presenting between 12 and 24 hours of onset and over the age of 80, owing to the paucity of data in these groups. So it has to be a case by case discussion between the referring team and the comprehensive stroke units when the patients are beyond 12 to 24 hours. Right. So now we are just going to take you through some basic things that you need to know when you're interpreting CTP radiographic features. So carefully listen to the terms that we are going to use. We are going to use the word core, indicating that that area of the brain is dead. We're going to use the word penumbra, indicating the area of brain that is salvageable, and that is what we are aiming to retrieve by doing thrombectomy. And we also need to know about collaterals. How long can the brain stand when there is a large vessel occlusion? So that is very, very important in making a decision and judging on travel times. I want you to just now focus on some of the key things that will come up on your CT perfusion when you're looking at them. So you'll see something called the CBF. If the CBF here means cerebral blood flow, less than 30% indicates that is the core brain that is dead. You'll see another index called the Tmax greater than 6 second, and that is the brain that is oligemic. That explains the amount of brain that is oligemic. And the next one, you'll see the mismatch volume, and that will tell us the amount of brain that is salvageable, and that is the penumbra. And then you will see mismatch ratio. Mismatch ratio of greater than 1.2 is a CTP criteria for eligibility for thrombolysis. And that's what I had previously mentioned in my guideline slide. So we also need to know about certain other things that will come up on your CTP perfusion. Tmax greater than 10 seconds indicates that these are the area of the brain that is immediately at risk of infarction. That's the group. That's the area of the brain that is a high risk of infarcting very, very soon. You will see two other things that we need to look for to look at the collaterals of the brain, called the hyperperfusion index. If the hyperperfusion index is less than zero point 0.5, that means they have got very good collaterals. And you'll see another index called the CBB index. And if that is greater than 0.75, that means they have got collaterals. So for collaterals, you need to focus on two things: hyperperfusion index less than zero point 0.5, and the CBB index of greater than 0.75. So I'm now going to take you through a very basic CTP example. So we've looked at what are the indexes that we need to look for. So on the sequence of the CTP images, this is the first thing that you'll be seeing. The CBF less than 30% indicates the amount of brain that's dead, the core. Here it is 0 mils. That means there is no core in this interpretation. On the right side, you see the Tmax greater than 6 seconds. That is 74 mils. That is the oligemic area of the brain. And now you see the mismatch volume is 74 mils. That's the penumbra that is could be easily saved. And the mismatch ratio is infinite, means that's more than 1.2. That means this patient is eligible for thrombolysis. Right, on this slide, you have to focus on two things. The Tmax greater than 10 seconds is 20 mils. That is the area of the brain that is going to be infarcted very soon. That's just giving us a warning that 20 mils of the area is the area that is at risk of infarction very quick. And you can just see the hyperperfusion index, which says it is zero point 0.3. As I mentioned, anything less than 0.5 indicates it's a good collateral. On this slide now, you can just see the CBV index. As I mentioned in the past, that a CBV index of greater than 0.75 indicates good collateral. And in this slide, you can just see that the CBV index is greater than 0.75, it's 0.9. So that indicates that this patient has got good collaterals. So once you have seen the key indices that I have mentioned, that we need to just quickly go through some of the slides that will come through on your CTP. And this is just to make sure that the acquisition of the CTP perfusion was adequate. There was no movement artifact. So you'll see something called the bolus time, which includes the arterial and venous phase on the MCA and the superior sagittal sinus section. Then you'll see something like this, which more or less needs to be slightly like a straight line. There should not be lots of ups and downs. If it's more or less like a straight line, that indicates that the patient is not moved during the acquisition of the CTP. On the last slide, you'll see two curves, a red curve and a blue curve. It will have an upward slope and a downward slope, and then it will even it out. The red slope indicates an arterial phase. The blue curve indicates a venous phase. As far as it got a symmetrical up and a downward slope with a flat line after that, that more or less indicates that this is a good CTP, and it's called the adequate time density curve. So these are the things that you will be seeing in your CTP. So basically, the CTP will give you information about the core, the oligemia, the penumbra, the mismatch volume, and it also details about the collaterals. And based on the available information, you will be able to make a decision on not only on thrombolysis, also to discuss the patient for thrombectomy with the comprehensive stroke unit. So these are the basic sort of CTP findings that I have discussed. Now, along with Dr. Maha Abdulghani, we will be discussing some real-life cases with CTP interpretation and how a decision is made and how the outcomes of these patients have turned out to be. Many thanks for your attention. Welcome back to our online module. So we are now going to discuss some real-life cases that we have treated in the Royal Stoke Hospital at the University of North Midlands. So I'm just going to do this along with Dr. Maha Abdulghani. And the first case that we are going to see now is an 88-year-old gentleman whose modified Rankin is 4. He's a wake-up stroke. He went to bed at 10 p.m. at night, noticed by his family. He woke up with stroke symptoms at around 6 o'clock in the morning. He presented to A&E at around 9 a.m. His NIHSS score is 12. So basically, from the information that we've got, this patient's Rankin is 4. So clearly, we are not going to think about thrombectomy here. So we need to really make a decision whether this patient is eligible for lysis. So I'm just going to pass on to Maha with that information to see whether this patient would be a candidate for thrombolysis, because we only got some information about when he went to bed and when he woke up. Over to you, Maha.
Okay. So you are saying here that he has modified Rankin score, as you've said, definitely is not for thrombectomy. Are there any contraindication for lysis?
No, there are no contraindications. We've gone through the lysis, we've gone through the medications. The patient is not on any anticoagulation. And there is no other major contraindications for thrombolysis.
Okay, so based on the new criteria, the patient might be candidate for lysis if meet the CTP criteria.
All right.
But let's have a look at the wake-up stroke. So you are telling me that this patient
went to bed at
10 p.m. Then the patient woke up at 6 a.m. This means that this patient had 8 hours of sleep.
Yep.
This means that the midpoint of sleep is 2 a.m. And basically 9 hours from that, this means that we can lyse this patient till 11 a.m.
Right.
This patient came to A&E at 9 a.m. So we still have another 2 hours and we can lyse the patient. So let's have a look at his scans. Okay, this is the plain CT scan. Plain CT scan looks good. There are no any acute ischemic changes. Aspect score is around 10. Then also had CTA done, is fine. Okay, let's have a look at his CTP.
Okay.
So CPF less than 30% is 0 ml. This indicates that there is no core even.
Okay.
Usually in CTP criteria for lysis, if CPF less than 70, we can still lyse. So this is a good number.
So just to re-emphasize, if the core is less than 70 mils on the CBF criteria,
yes,
that is a good case to lyse.
Exactly. We have, as you have said earlier, we have 3 main criteria to actually fulfill. One of them is CPF less than 30%, which is the core, less than 70 ml. So in this case, it's 0 ml. And the other one is the penumbra to be more than 10 ml. In this situation, it is actually 18 ml, which is a good number as well. And the third criteria is the mismatch ratio to be more than 1.2. In this situation, it is infinite, which is pretty good. So based on this slide, the patient does meet the criteria of lysis based on the CTP criteria.
Okay.
Let's just have a look at the others parameters. Just hypoperfusion index 0, which is good actually. As long as it's less than 0.5 is good. And CPV index 0.7 acceptable. So in general, based on the previous slide, the patient is meeting the criteria of lysis. I will lyse this patient. What happened with this patient exactly?
So as you had mentioned, we did thrombolyze this patient according to the wake-up stroke criteria. The NIHS score on discharge was 2 from 12, and that was a good outcome for the patient. Right, now going through the second case, we've got an 85-year-old lady who presented with sudden onset of face, arm, and leg weakness around midday, 12 p.m. And there was a delay in arriving into hospital, presented to ED at around 7 p.m. NIHSS was very high at 16, and this patient was fairly independent prior to having the stroke, and our predicted modified Rankin on this lady was 0. Can we just take through this case, Maha?
Okay, so we are talking about a patient whose modified Rankin score of 0 and with NIHS score of 16.
Yep.
And this patient came after 7 hours from the stroke onset.
That's right.
So basically, this patient is still within the extended window of lysis and can be actually lysed / has a thrombectomy if needed.
Yes, so eligible for both lysis and thrombectomy.
Exactly. Yeah. So again, I wonder any contraindication of for lysis?
No contraindication for lysis. And as you had emphasized, based on the NIHSS and the modified Rankin and the onset time, we feel that we have to screen this patient for eligibility for lysis and thrombectomy.
And thrombectomy,
okay.
Exactly.
Okay.
So let's have a look at the scans.
Yep.
Okay, this is the plain CT scan. Actually, there are no clear ischemic changes. E aspect is 9, just only this area.
Yeah.
Okay, so this is good. Then we have the CTA showed actually M1 thrombus, LVO.
And that is in keeping in with the clinical presentation of a dense left-sided weakness.
Then we have the CTP here. Okay, let's go through this. CBF less than 30% is 5 ml.
Yeah, so it's less than 70 mils.
Yes, it's not a large number.
Yep.
Mismatch volume is 85 ml. This is the penumbra that we are trying to save.
Okay.
It's a good number as well.
Mm-hmm.
Let's talk about the lysis first.
Yep.
So for lysis criteria, this patient does meet the lysis criteria.
Mm-hmm.
CBF less than 30%, the core is only 5 ml.
Okay.
Again, as we've said, as long as it is less than 70 ml,
Yep.
then this is a good number.
Okay.
Mismatch volume, which indicates the penumbra, is 85 ml.
Yep.
As long as it's more than 10 ml, then this is good for lysis.
Okay.
And the mismatch ratio is 18. As we've said, as long as it is more than 1.2, then this is a good number for lysis.
So at this stage, this patient is good for lysis?
Definitely, the patient is a candidate for lysis based on the CTP criteria for extended window of lysis.
Okay.
Also, these numbers are good for thrombectomy as well, but let's have a look at other numbers as well. So if you look at the T max more than 10 seconds, it's 42 ml. Again, we keep emphasizing on this, time is brain.
Yes.
We should send that patient to thrombectomy and do lysis as soon as possible, because there is 42 ml of the brain that might actually be lost very soon, which is important. Let's have a look at the collaterals. The hypoperfusion index is 0.5. It's acceptable one.
Okay.
As we said, if it is less than 0.5, is a good collateral. If we look at the CPV index, again, another parameter for collateral, it is 0.9. It's a good number. Again, if it is more than 0.75, it's a good number. So in conclusion, this patient meets the criteria for lysis, the CTP criteria for lysis. Also, the CTP numbers are good for thrombectomy as well. So in my opinion, this patient should have both lysis and thrombectomy.
All right. Okay. So as you had said, this patient had thrombolysis and thrombectomy, and the NIHSS score on discharge improved from 16 to 2. Maha, there's just one question I want to bring in for discussion, just going at the timeline. So this patient came into ED from the onset time, we knew it was 7 hours.
Yeah.
So based on that, with the extended window for lysis, we decided that the patient is eligible for lysis and thrombectomy. I'm just bringing in the discussion. What happened if this patient presented at around 9:30? So would we not consider the patient for lysis because it was beyond the extended window and consider only for thrombectomy?
Well, theoretically speaking, and based on the guidelines, this patient exceeds the 9-hour window of lysis of non-onset. So unfortunately, the patient will not be candidate for lysis, but still could be a clinical decision because it's only half an hour past the 9 hours.
Yeah.
So it should be a clinical
decision. So on a case
decision.
by case.
Exactly. Yeah.
But if you go to guidelines,
if you go to guidelines, the patient is outside the window.
Outside the window for lysis, but within the window for
thrombectomy. Yes. If we are talking about 9.5 hours.
Okay. Yeah. So that's quite clear, and that's the reason why I just wanted to bring the importance that the guideline says the extended window is up to 9 hours for lysis, but it's different for thrombectomy. And clearly, this patient would have had thrombectomy alone if presented beyond 9 p.m. on that particular day.
Exactly.
Okay.
Yes.
All right. Now we are going to the next case. We are going to case 3. Right. Okay. The next case is slightly different, and there's a 60-year-old gentleman presenting with sudden onset, dense right-sided weakness, face, arm, leg, and some speech disturbance. Presented within 5 hours of onset. Patient is known to have atrial fibrillation. Is on apixaban. Compliance has been checked. Patient is compliant with the medication. Last dose was 6 hours ago. NIHSS is 12, Rankin is 0. So Maha, can you just take us through this case?
Yeah. So we are talking about 5 hours onset. But at the same time, the patient is on apixaban.
Absolutely, yes.
So is on apixaban, and we know for sure that the patient took apixaban 6 hours ago.
Yeah, we'll confirm that.
So far, the patient won't be a candidate for lysis.
Yeah.
But with NIHSS score of 12 and modified Rankin score of 0, the patient may be a candidate for thrombectomy. So let's have a look at the numbers. So the plain CT scan is fine.
Yeah.
Aspect score is only 9. There are no proper ischemic changes here.
Yep.
CTA showed actually
a large vessel occlusion.
LVO, also M1 thrombus.
Okay.
Okay, so the CTP here shows a core CPF less than 30%, which represent the core is only 5 ml.
So definitely less than 70 mils.
Here we don't care whether it is less than 70 ml or not. Again, this patient is not a candidate for lysis.
That's very important, isn't it?
Yes.
So the core is only emphasized when you're considering a patient for lysis.
Actually, based on the guidelines, there are no core criteria
for thrombectomy. Okay, that's a very important point that we need to emphasize here.
Exactly.
So the core is only used to decide lysis, but not for thrombectomy.
Yeah. And mismatch volume is 26 ml, which indicates the penumbra. Then we have Tmax more than 10 seconds is 0 ml, which is good. Yep. Again, that brain is holding. Hypoperfusion index, which indicate the collaterals, is 0. Again, this indicates good collaterals.
Okay.
Just to emphasize again, if hypoperfusion index less than 0.5, this indicates good collaterals.
Okay.
And we have CPV index 0.7, which is acceptable for collaterals.
Okay.
This patient need to go for thrombectomy for sure.
Yep.
But we might have some debate here, which is the necessity of CTP in such case. Basically, according to the guidelines, within the first 6 hours, you can just, there are no certain imaging criteria to send the patient for thrombectomy. So even regardless of that CTP, the patient need to go for thrombectomy. However, the CTP was good for us to reassure us more that we have good numbers and we need to send the patient for thrombectomy with possible good prognosis after that. So what happened with that patient exactly?
Okay. So this patient did go for thrombectomy, and NIHS score on discharge was 1, so improved from 12 to 1. So just to go back and just see if the scenario was slightly different, Maha. Let us assume that we had established that patient was already on apixaban, but we are certain that the patient missed the dose or did not take the last 2 doses or the last dose. If that was the situation, would you have considered this patient for lysis and thrombectomy?
Yeah, but again, it's the usual lysis indication, contraindication criteria. If the patient did not take apixaban for 48 hours, then the patient might be candidate for lysis. But in such situation, it's very clear that the patient already took the last dose 6 hours ago. So, that's why
clearly a
what makes the patient actually not a candidate for lysis.
Okay.
But the main issue with this patient is the patient only came after 5 hours. So basically, even the CTP does not carry a big importance in such situation. But however, it
just emphasizes
it does make a difference.
Absolutely.
Yeah.
Okay. So we are just saying that the aid of CTP just helps us to make the decision a bit more confident.
Yeah, exactly.
Yeah. Okay. So next case, Maha, is a bit more challenging. So we've got a 63-year-old lady who presented with right-sided weakness and dysarthria 13 hours ago. So this has been transferred from a spoke center. Was diagnosed to have a partial anterior circulation ischemic stroke 2 days prior to admission with NIHSS of 2 and was started on DAPT. So patient has had probably a second episode. So 2 days ago had a sort of a stroke with a low NIHSS and started on a dual antiplatelets, but now is come in with an admission NIHS of N17 and the modified Rankin is 0.
Okay, so we are talking about a very recent stroke.
Yeah, very recent stroke, and then the patient has possibly went on to have a possible large vessel occlusion, despite being on DAPT, and the NIHS is quite high. From 2, it's gone up to 17, and the modified Rankin is 0.
And the onset is 13 hours ago. So we have different reasons not to lyse this patient.
Yeah.
Recent stroke and actually outside the window of lysis as well.
Yeah.
So basically, lysis is off the table for this patient. But as you've said, still this patient might be a candidate for thrombectomy.
That's right. So that's what we're going to assess now.
So this is the plain CT scan. Just a few ischemic changes, aspect maybe 9 or 8.
Okay.
Then definitely we have a proximal M1 occlusion as well.
Matches with the high NIHSS.
Yeah, and LVO is definitely there.
Yeah.
So let's have a look at the CTP here.
Yep.
CPF less than 30% is 47 ml.
So because you're considering this patient for thrombectomy, that doesn't matter.
Yeah, but this is the core. At least we need to know our numbers, prognosis-wise, etc.
Okay.
Yeah. So CPF less than 30% is 47 ml. This is the core.
Yep.
We cannot save that, unfortunately.
Yeah.
Mismatch volume is 128 ml. This is a very large penumbra that we can save, and we need to save actually. Then we have Tmax more than 10 seconds, 87 ml.
Yeah.
Again, I keep emphasizing in that time is brain. We need to send that patient to thrombectomy as soon as possible because this area will be lost very soon.
Very soon, yeah.
Let's have a look at the collaterals. Here, the hypoperfusion index is 0.5.
Okay.
It is acceptable on the borderline. And the CPV index is 0.8. Again, as we've said, it's more, if it is more than 0.75, this indicates good collaterals. So in general, this patient has considerably not large core, a very large penumbra, and a pretty good collaterals. So I will send that patient to thrombectomy.
Okay.
What happened with this patient?
Right. So this patient, absolutely, as you rightly discussed, we didn't consider for lysis because outside the guidelines and the window for lysis, patient did have a thrombectomy, and the NIHS score on discharge was 2.
Oh, that's good.
Yeah. So I just wanted to, for the purpose of discussion, I'm just going to go to this section, Maha. So you emphasized that the core in this patient was 47 mils, and as for thrombectomy, there is no core size that needs to be considered. But you clearly said that there was a mismatch volume of 128 mils, which indicates there was a large penumbra. I just want to ask you, say, for example, if the core was 100 mils, right, and you had a mismatch of 75, and you also said that the Tmax greater than 10 was 87 mils. That means, there's a large amount of brain that is going to get infarcted very quick, right?
Yeah.
If you don't intervene. Say, for example, I'm just throwing a question. Say, for example, this is in a spoke center, and your decision is based on if you had a core of 100 mils with a Tmax 10 of,
Of, let's say, maybe 70 or
70. Yeah.
So you are basically talking about a very large core.
Yep.
With a Tmax more than 10 seconds that indicate that this brain is going to be dead very soon.
Very soon.
So what are you going to do?
Yeah.
So again, theoretically speaking, based on the guidelines, this patient still can be offered thrombectomy.
Okay.
Because based on the national clinical guidelines, they say irrespective of the core size, you can offer thrombectomy for the patients.
Okay.
Nowadays, we are not talking about keeping all patients with modified Rankin score 0, 1, but the whole idea is to improve their life.
Yeah.
So some patients without a thrombectomy might end up with a modified Rankin score of 5 or 4, but with a thrombectomy, they may end up with 3 or 2. So this is considered a improvement. That is number one. This is from a theoretical point of view and guidelines point of view.
Okay.
But at the same time, even within the guidelines, they always mention that the scans should be interpreted based on the clinical experience and the clinician experience.
Okay.
So in your scenario, you are talking about a core of 100 ml.
Yes.
And the brain might be gone very soon. So this is a difficult situation. We, especially with the transportation time, etc., unfortunately, we may not be able to save that brain.
Okay.
Because with time of transportation, with time of preparing everything in the comprehensive center, sometimes this will make things more complicated.
Right. Yeah. I mean, this is real life, isn't it? Because with all the challenges of getting a patient from the spoke to the comprehensive site, with that large core and the high Tmax, the outcome could also be very bad.
Yes.
Or we might even make a decision when they come too late. We might not be offering thrombectomy as well.
Exactly, and it should be informed decision with the family as well. They need to understand the situation.
Yeah. Okay. Right. So the next patient, Maha, is an 88-year-old gentleman, again, unknown onset of right-sided weakness. So we do not know the onset time, dense right-sided weakness, aphasic right arm, right leg weakness with conjugate deviation of the eyes to the right. Last well seen 24 hours ago. Admission NIHSS was 18, a modified Rankin score of 1.
Okay, so we are talking here about another category, which is unknown onset stroke.
Yeah.
So the patient has unknown onset stroke and NIHSS score of 18 with modified Rankin score of 1. Again, before going into any other details, theoretically speaking, this patient might be candidate for both lysis and a thrombectomy if meeting the criteria.
Okay.
Just want to ask, any contraindication for lysis for this patient?
No, we've gone through the past medical records and checked with GP records. There is no contraindication for lysis.
Okay. So let's have a look at the scans.
Mm-hmm.
Okay, this is the plain brain CT scan.
Yeah.
It looks actually pretty good for a patient with unknown onset, and there are no clear early ischemic changes on the scan.
Yep.
So let's have a look at CTA showed a proximal M1 occlusion.
Yep. Yeah. Fits in with the clinical picture.
Then we have the CTP. So if we have a look at this CTP, CBF less than 30%, which indicates the core is 0 ml. Oh, that's good.
That's good.
There is no core at all. Yeah.
Mm.
Yes. Mismatch volume is 84 ml, so a very big penumbra. Mismatch ratio is infinite.
Okay.
So, as we said before, this patient, although the patient is unknown onset stroke, but still the patient is a candidate for lysis. So based on these numbers, the patient is a candidate for lysis based on the CTP criteria. Again, the core is 0 ml. As we said before, if it is less than 70 ml, then the patient meet that criteria. The mismatch volume is 84. As we said before, if it is more than 10 ml, then the patient meet that criteria, and the mismatch ratio is infinite. And again, as we said before, if it is more than 1.2, then the patient meet the criteria. So this patient meet the 3 criteria for lysis in extended window of unknown onset stroke. Definitely this patient will need lysis, and even the numbers are good for thrombectomy as well. But let's have a look at just the whole picture here. Oh, wow, have a look at this. Tmax more than 10 seconds is only 10 ml.
Yeah.
So even we still have time, and the brain is still very viable.
Okay.
Hypoperfusion index is 0.1. Oh, that's pretty good number actually. Definitely this patient has very good collaterals. Again, as we said, hypoperfusion index, if it is less than 0.5, this indicates good collaterals.
Okay.
And CPV index is 0.8. Again, a good indicator of collaterals. As we've said before, if it is more than 0.75, it indicates good collaterals. So, in general, this patient meet the criteria for lysis based on the CTP criteria, has also good indicators for thrombectomy as well, with good collaterals. So I will definitely send that patient for both lysis and thrombectomy.
All right, let's see what happened. This patient had lysis and thrombectomy with the unknown onset time, and NIHs on discharge was 4.
Wow, that's
yeah. So I'm just going to bring the discussion back to. I'm just going to change the time windows and ask your opinion. So this was unknown onset of right-sided weakness. So according to the guidelines, this patient was eligible for lysis and thrombectomy. What if we knew the onset time and the onset time was more than 9 hours?
Yeah, if the onset time is more than 9 hours, unfortunately, the patient does not meet actually the criteria for lysis. It's because basically they have only studied up to 9 hours, so we cannot extend it more than 9 hours, even with good CTP like this.
So it's a bit challenging, isn't it?
Exactly, but unfortunately we can't just lyse patients even if we see that this is the situation. If we really know the onset time, it's difficult if it is more than 9 hours.
9 hours, and it will be the same if you use the wake up time using the midpoint criteria, and if it's more than 9 hours.
Same thing. If it is more than 9 hours from the midpoint of sleep, then unfortunately we cannot lyse. We are not supported by any evidence or guideline to lyse such patients, unfortunately.
So despite having a CTP, which shows that there is no core and a lot of salvageable brain, just because of the way the guidelines are.
Yes, unfortunately we can't.
We will not be able to lyse, but we would have taken the patient for thrombectomy.
Yes, there is no evidence to lyse such patients, unfortunately.
I think these are the places where there'll be a lot of debates between clinicians. It'll be case by case.
Exactly.
So here we are just talking through guidelines, but as we said, all these that we are using is to make an informed decision on lysis and thrombectomy, and there'll be a sort of a variation and debates on taking the patients for lysis and thrombectomy.
Yes, actually, it was amazing that now we have extended the window of lysis to that extent. Hope so in the future this window might be extended much more than this.
Okay. Right. So now we are moving on to a slightly more difficult cases. All the cases that we've seen so far, I don't think the decision-making process was that difficult. If we knew the onset time and we stuck to the guidelines and the CTP criteria. So now we are going to see some difficult scenarios, right? Okay. Right. Okay. So this is a person, it's a 74-year-old lady coming in with dense right-sided weakness and aphasia. Last seen 19 hours prior to A&E arrival. So that's a long time to come into A&E. Probably the patient was on her own in the house and was found very late. And admission NIHSS was 18. This lady was previously fit, well, independent, driving, self-carrying. Unfortunately, has had a big stroke and has arrived into A&E 19 hours after the onset of stroke.
Okay, so actually this scenario looks similar to the last patient who had unknown onset but last seen well more than 24 hours.
Absolutely.
So from history point of view, the previous patient and this patient almost share
same
similar,
sort of,
yes,
because the onset time is unknown.
Exactly, it was unknown, and the previous patient was last seen well more than 24 hours, and this patient was last seen well 19 hours ago.
Yeah.
Okay, so still we are talking about unknown onset.
Yep.
NIHSS score is 18.
Yeah.
And modified Rankin score of 0.
Mm-hmm.
So again, theoretically speaking, this patient might be candidate for both lysis and thrombectomy if the scans are favorable.
Okay.
Any contraindication for lysis?
No, we have checked through the medical records. Patient not on any anticoagulation, and no major contraindications for thrombolysis.
Okay, let's have a look at the scans. Okay, I can reassure you that this is definitely not the same case as before.
Yeah.
If you remember the previous case, the plain CT scan was absolutely normal.
Yeah.
But if you look at this scan, definitely there is an established infarct
You're
here.
Right. Okay.
Yes, there's a proper hypodensity here.
Uh-huh.
Somebody can argue that, yes, if you look at the aspect score, this might be maybe 5. Yeah, but definitely there is an established infarct here. Let's have a look at CTA. Definitely shows that there is M1 occlusion.
Yep.
Okay, this is the CTP. Oh, okay, this is a very tricky situation.
Yep.
Have a look at the CPF here, less than 33 ml.
Yep.
It is, this is the core.
Yep.
And it is exactly similar to the previous scan that we saw here. The plain CT scan.
Yep.
So this is the established infarct, and the CTP showed the established infarct again.
Yep.
Then the penumbra, the mismatch volume is 98 ml.
Okay. So
theoretically speaking, we still have some area to save. Okay. This area might be still saved. This area. Okay. Again, let's talk about theory here. Lysis. If you just want to look at the scans, just the numbers, you will say that, okay, blindly, the CPF less than 30% is 33 ml.
So less than 70 ml.
Less than 70 ml.
Yep.
Yeah. Mismatch volume is 98, more than 10 ml.
Yeah.
And the mismatch ratio is 4, more than 1.2.
So fits into the
criteria. So maybe, fits criteria for lysis.
Yeah.
Yes, exactly. Though I don't believe anybody would lyse this patient with this established infarct. That is because the risk of bleed with such established infarct and lysis is very high, no doubt about this. From thrombectomy point of view, it is debatable, to be honest. Some might say that although we have an area that is already dead and with established infarct, but you can still save other area, which is the rest of the penumbra, this area, the penumbra.
Yeah.
So it is debatable. I think some physicians may go for at least a thrombectomy, while others will not go for thrombectomy. And I don't believe there is a right or wrong actually decision here.
So, but if you just go purely on the guidelines, this patient is eligible for lysis and
and a
thrombectomy.
thrombectomy based on the guidelines.
Yeah.
But still, as we said again, the guidelines are not blind.
Yeah.
They always say it needs clinician interpretation
Intervention.
of the whole
Okay.
situation. Again, let's continue looking at the scans. The hypoperfusion index is 0.3, less than 0.5.
Okay.
Again, this indicates good collaterals.
Yeah.
And okay.
So can we just go through the Tmax?
Tmax more than 10 seconds is 44 ml. Yeah. So some area will die soon. Yeah. But still, it's very difficult. You do have an established infarct. If you lyse such patient, this patient will definitely end up with a bleed. Okay. If you send that patient for thrombectomy, we don't know how much this will benefit the patient, what will be the final outcome in such patient. Again, in such situation, the possibility of developing a bleed is still very high. Okay. I think it will depend on the clinical decision of the whole situation. Again, we are not just reading scans here. Yeah, we need to look at the patient, their needs, their wishes, their medical situation, social situation, etc., in order to decide on such cases. Just by looking at these scans, definitely we are not talking about lysis, despite meeting the criteria of lysis on paper. And regarding thrombectomy, for me, I will not send that patient to thrombectomy. Okay. I'm not sure what happened exactly with this patient, but for me, I'm not sending, though I don't believe it's a wrong decision if this happened.
Right. So what exactly happened? This patient did have a thrombectomy, and after a lot of debate, as you had rightly said, that we didn't thrombolize this patient, and the patient did have a post-thrombectomy hemorrhage into the infarcted area, although that resolved. But in terms of the NIHS score, there was not a huge shift.
It was the same. Again, even with this NIHS score, some might argue, because the whole idea that they were trying to save the part of the penumbra. Yeah. Not basically saving anything about the already infarcted area. Yeah. So for them, maybe even having the same NIHS score is considered success in such situation.
Yeah, possible.
But so still, it is very debatable case.
So we are going to face in real life situations like this. So I'm just going to go back to this scan just to bring the discussion about. Let us assume the same story. And let's assume that there was no established infarct there, and the aspects was around 9 or 10.
Yeah, it will be like the previous
case. So in that case, if there was no established infarct, then the patient would have gone for lysis and
exactly.
thrombectomy.
Yes, just like the previous case. Yeah. Actually, these two cases were very similar. Yeah. The only difference that the previous case did not show any changes in the CT scan, the plain CT scan, while this patient unfortunately had already established infarct, established changes, and that's why this case is more complicated than the previous one. The previous one was just a straightforward. Unknown onset. We did a plain CT scan. Plain CT scan was fine. Then we had a look at the CTP, CTA, CTA LVO, CTP meet the criteria of lysis and for thrombectomy as well. So we sent the patient for both lysis and thrombectomy. But this patient with this kind of infarct, it was a difficult situation. I don't believe anybody will disagree about lysis in such situation, not to lyse the patient, but the disagreement might be about the thrombectomy in such situation.
I'm just going to put you on the spot. Say, for example, this was daytime, and you were the frontline clinician, and the CT was done, and the radiographer calls you and says, you've seen the CT showing an infarct. Do you still want to go and do an angio and a CTP, or would you stop and say, I don't think I'm going to do anything there because the stroke is established? Or would you still think, right, maybe not a candidate for lysis, I still want to do an angio and a perfusion to see the patient would be eligible for thrombectomy? What would be your thought process?
Well, I think these cases should be handled individually, case by case.
Mm-hmm.
It will all depend on different aspects about the patient, the exact scenario, etc. Honestly speaking, I just had a very similar situation recently with one of the patients. I was called by A&E to see a patient who was unfortunately filled of dried feces all over her body, and her family were around. So I was asking them what happened exactly. I wanted to establish time of onset or anything like that. Eventually I realized that that patient was last seen or actually contacted by her family 5 days ago.
All right. Okay.
And her medical situation, she had actually she was on dialysis. EGFR was between 5 to 7.
Okay.
So I simply decided to do triple scan if the plain CT was okay.
Okay.
So it depends on the situation.
Situation.
In that patient, the plain CT scan showed established changes. So I thought this is risk versus benefit.
Okay. So
I should not put more contrast to this
Yeah.
patient. It will be more
Okay.
harmful to her. So again, it will depend on
a
the
case
by case, the general situation of the patient,
Yep.
the history, etc.
Right.
Before deciding whether you should continue with the triple scan or
So
not.
the message is treat the patient, not the scan.
Exactly.
The scans are used as an adjunct to make a decision on lysis and thrombectomy.
We should always emphasize on the importance of history and understanding the whole situation of the patients, the needs of the patients, before actually jumping onto decision of doing something.
Very important. Right. Okay. So that was an important lesson. Now we are going to.
Oh, that is what is this? Is this a post thrombectomy scan?
Oh yeah, sorry. So I just want to show what was the post thrombectomy scan.
Oh, okay, so the patient had some bleed after.
Yeah, so despite the thrombectomy, I think we did anticipate that there was going to be some established infarct. There was post-lysis hemorrhage. It was not that bad.
Yeah, but again, if you look at the scans, the scans showed almost similar infarct size to the original one before thrombectomy.
Yeah.
So again, someone might argue that they could save the rest of the penumbra.
Yeah. So one might say that if we had not done the thrombectomy, the NIHS would have worsened, or even progressed to a malignant MCA syndrome.
Exactly.
So we have salvaged some brain,
yes,
but we have not shifted the NIHS.
Exactly. Someone might just say, yes, we've saved this patient from developing malignant MCA or something like this.
All right. Okay. So so we have to emphasize that don't forget to look at plain brain CT scan while interpreting CTP. It's very, very important. So, that is the purpose of looking at all the scans together. And, as we were discussing, sometimes we might need to look at the CT and say, all right, we are stopping here because on a basis of the information from the patient and an established infarct, we might not go ahead and do anything further, or we might need more information to see whether the patient would be still eligible for an intervention.
Yeah, I think this is very important statement here. Yeah. We should not just look at the CTP and interpret the CTP separately from the CT and CTA. Because basically CTP interpretation might be affected by the plain CT and the CTA. So for example, if you have established changes on the CT, then this will affect your interpretation of the CTP.
Okay.
And in CTA cases, sometimes if you have significant stenosis in the carotid, this will also affect the interpretation of the CTP. And that's why we should always interpret the 3 scans together, not just only looking at one scan and just put our whole interpretation on that scan without looking at all scans together. And of course, patient is always comes first. We need to understand
patient
the
is the
patient's
center of
needs as
decision
well.
making. Yeah. Okay. Right. So now we are coming to the last case of this module. And again, we put this case just to bring in the emphasis how CT perfusion needs to be carefully interpreted when somebody comes into hospital within an hour or within 2 hours of onset. You need to have extra caution. So I will take you through this very important case. We've got a 73-year-old gentleman who presented with right-sided weakness. It was a very dense weakness. He had speech disturbance, aphasic. He was conjugate deviation of eyes, no movement in the right arm, right leg. Fortunately, I mean, I'm saying fortunately because the daughter was there, so she witnessed the stroke. She's seen the advert on TV. She clearly knew dad had a big stroke. She didn't waste time. They called the ambulance. The ambulance were within 10 minutes. They came into a hospital within an hour from the stroke
Wow,
onset.
that's a perfect timing.
So that's a sort of the golden hour. So this patient, despite having a large territory stroke, was in the right place at the right time. NIHSS was 22. This person was absolutely fit and well, plays golf, washes dresses, drives, looks after the grandchildren, takes them to school. Very sad that he had a catastrophic stroke, but he's in hospital within an hour.
Wow, I have to admit this is a perfect timing. Yep. We do not see such time
that's
that
right.
often.
We dream that our patients should come to 1 hour, but that doesn't happen in real life. But this person has really arrived within the hour. Can you just take us through this case then?
Oh yes. So NIH score is 22, which is high actually.
Yeah, it's large. Yeah.
Modified Rankin score is 0.
Yeah, he's a fit and well guy.
Yeah. So basically, this patient, any contraindication for lysis?
No contraindication for lysis. No surgeries. He's not on any anticoagulation.
Yeah, with such high NHS score, I'm sure that this patient will end up with LVO. So basically, this patient theoretically looks like might be candidate for both lysis and thrombectomy.
Yeah, agree.
Let's look at the numbers and see. Okay, so this is the plain CT scan. I'm not sure if these are really ischemic changes here. I know the E aspect says here 3, but I'm not sure about this. Do we have any scans? Oh, perfect. Yeah. So based on these scans, actually, there are no proper ischemic changes.
So pretty good scan. Yeah. Pretty intact brain.
And this is the CTP.
Right.
Okay, so let's have a look at the CTP. CPF less than 30%, which indicates the core is 80 ml.
Okay.
How come it's 80 ml? We'll see. Mismatch volume is 99 ml,
okay,
which is good number actually.
Sorry, Maha, can you just keep the? I'm just going to throw in some questions on this one. So just looking at that, the core is 80 mils, the T max is 179 mils, the mismatch volume is 99, and the mismatch ratio is 2.2.
Yeah.
Yeah.
So for lysis, just only actually by looking at this scan, I would have lysed the patient immediately on the table.
Right. Okay.
So yeah, that is very important. Again, we should not. This patient came within a very great timing, so we should actually lyse as soon as possible. So
right. So now that's for sake of debate. If you just go to the CTP,
just only after the CT, I would have lysed the patient.
Okay. But let's assume
we don't even need a CTP in such situation to lyse a patient. So I would have immediately lysed the patient on this CT scan.
All right. But I'm just real life. So let's assume that this patient has had CT, CTA, and CTP. This patient has come back to ED. Now we are making a decision on lysis. And so far in the course, we have said that the criteria for thrombolysis.
We don't need any criteria for thrombolysis. The patient only came within 1 hour of the onset of stroke.
Okay, but what about the core on here with the CBF of 80 mils? We said if the core was greater than 70, according to the guidelines, it is not a candidate for lysis.
No, we don't. First of all, again, this patient only came within 1 hour of onset.
Okay.
So we don't need even any CTP criteria to lyse a patient. Just look at the plain CT scan, which is this one. Once you have a look at this plain CT scan, we should immediately lyse a patient. We don't care about the CTP criteria because we don't even need the CTP criteria. The CTP criteria are only needed in the extended window of lysis, meaning wake up stroke, unknown onset stroke, or known onset between 4.5 hours till 9 hours. Otherwise, we do not need the CTP criteria.
So in this case, we should have just limited our imaging with CT and CTA.
Why? The patient is candidate for thrombectomy. So definitely the patient will need all scans, but you can argue that even CTP is not needed for thrombectomy for such patient because basically the patient
within the hour,
within 1 hour, if it is normal CT scan, if the patient has actually LVO, then you can directly send the patient to thrombectomy, which is right actually. But again, usually we do the CTP
as a part of the NOCIP.
Exactly, and to support our decision, and also it will help us in actually any discussion with the family, with the expectations, prognosis, etc.
Right.
So
let's go through the scans.
It is useful. Let's have a look at this scan. Yes, you are actually concerned about this CPF less than 30%. Am I right?
Yeah, because as so far in the course, we have said 70 mils is a cutoff for the core for decision on lysis.
Lysis. We don't. There is no criteria for thrombectomy.
Yeah, I agree that it is a candidate for thrombectomy. So I'm just a bit worried if I'm a spoke center consultant looking at the core and thinking patients are out within an hour. I'm just a bit worried about the core.
So let's be realistic here. Let's have a look at the other scans, and I will explain something.
Okay.
So, sorry. If you look at the next scan, Tmax more than 10 seconds, it says 134 ml of the brain might go very soon.
Okay.
That's why we should really act very soon and very quickly with this patient. Hypoperfusion index is 0.7, not the best collaterals ever.
Okay.
And the CPV index 0.6. Again, unfortunately, this patient came very early to the hospital. But that patient did not have the best collaterals ever. And that's why the most important for us in such situation is to act as soon as possible.
Okay.
You have a very legitimate question, which is about the CPF less than 30%.
Yeah.
So if you have a look at the plain CT scan,
so
we know for sure that this patient only came after 1 hour.
Yeah, that's very certain.
From the stroke onset.
Yeah, because
we
the daughter
know that
was
for
there.
Sure. Yeah. And at the same time, we had this plain CT scan.
Yeah,
the plain CT scan looks fine.
Yeah, but what is confusing me is the CB.
You look at this, CPF less than 30% is 80 ml. So it does not make sense.
Absolutely.
So actually, it's all about the CTP interpretation again. And the CTP interpretation is not only with the CT and the CTA, it's also with the history of the patient.
Okay.
So CTP is all about the blood flow.
Yeah.
In any stroke, in the very few, the first few hours of any stroke, the blood flow to the brain will be less.
Okay.
And that's why it's very easy to find very early changes and such kind of a core on CTP.
Okay. That is because we scan the patient very quickly.
And because the blood flow in the first few hours of the stroke will be very low to the brain.
Okay.
And that's why you will find such kind of core. This is in reality called ghost core.
Okay.
It's not a real core.
Okay.
And in order to have a better representation of the core volume in such cases, you don't need to look at the CPF less than 30%.
Okay.
You need to look at the CPF less than 20%.
All right.
This is the only indication to look at CPF less than 20% as a representation of the core rather than the CPF less than 30%.
Right.
Usually, as you've said in the classical teaching, the usual scenarios, CPF less than 30% represent the core.
Yeah.
But just only in this situation, and I mean if a patient comes within the first few hours.
So what would be the cutoff? 2 hours?
They usually say, at the beginning, they used to say 90 minutes, and now you can say maybe up to 4 hours, something like this.
Okay.
For better visualization and assessment of the core, you need to look at the CPF less than 20%
as the accurate predictor of the
core, rather than the CPF less than 30%.
So
this is the only time and the only indication for CPF less than 20% to be the real representation of a core.
And you used the phrase ghost
core because it's not a real core. Yes.
So I think the message that we need to emphasize to people interpreting CT perfusion is, if somebody comes in very early within the first hour or 90 minutes and you do see a normal CT,
even up to 4 hours,
and you see a normal CT and then you see the CBF less than 30% as very high, don't take that as an accurate core. Just that for that time, go to look at CBF less than 20%.
Exactly.
Because that is what is going to give you the accurate core, because that will change your decision on lysis.
Exactly.
And that will take your mind out. So if you just go back to the previous slide, where we had the CB. So don't go on the 30%.
Don't go on the 30%.
Because based on that, you would not have lysed. Because the patient...
It's not about lysis, but it's about prognosis. As we said, in this patient, we are not talking about CTP criteria for lysis, but we are talking about prognosis. We are talking about confidence in sending such patients to thrombectomy. So for me, if I look at these scans with such plain CT scan, then after that, looking at these scans with not CPF less than 30, CPF less than 20%, and with a good penumbra to save, will definitely, as I said, lyse the patient immediately and then send the patient directly to thrombectomy as soon as possible.
10 was very, very high here, and this patient had very poor collaterals as well.
Exactly. So this patient...
So time is of brain here.
Very, very much.
Okay. Right. Let's see what we did.
Hope for lysis and thrombectomy.
Yeah, I think we would have done both. Yes, the patient had thrombolysis, thrombectomy. NIH score improved from 22 to 4. Very good outcome.
Yeah, that's very good outcome.
And I think the patient managed to walk out of hospital.
Oh, that's good.
So that was a very, very a positive outcome and a very, very interesting learning point.
Exactly.
About the interpretation of
very early onset stroke.
So can you just, for the benefit of the listeners, can you just go through the GHOST score?
Yeah, so the GHOST score is actually the previous case was an example of a GHOST score, which is, again, as I said, simply, and that's why it is very important to interpret the CTP based on the history, based on the CT, CTA, in order to understand how can you interpret the CTP. So if you have a patient with a very early onset stroke, meaning that this patient come to you within the first few hours, let's say maybe up to 4 hours, and you did scan for the patient.
Normal CT.
Of course, you need to have a look at the plain CT scan and interpret the plain CT scan properly. Then for the CTP, you should not look at the CPF less than 30%, but you should look for the CPF as the less than 20% as a proper representation of the core. And again, as I said, it's all about the blood flow to the brain.
I think
in the first few hours, the blood flow will not be that high, and that's actually how it is reflective on the CTP.
Excellent.
I think we can just emphasize on certain points here.
Oh, right.
It is very important for any physician who is interpreting the CTP.
Yeah.
First point is CTP, as we have said earlier, CTP may overestimate the core on admission, especially in the early time window of stroke. This is known as a ghost infarct core. In such situations, interpret plain CT scan carefully and consider CPF less than 20% as a core instead of CPF less than 30%. Another important learning point is CTP may underestimate the core if long-standing stroke. Again, this is the total opposite. Because collaterals will start working, cerebral blood flow will increase to that area, and thus will underestimate the core. And again, that's why it's important to look carefully to the plain CT scan. A third important point is that CTP may overestimate penumbra in cases of carotid stenosis. And that's why we said it's not only look at the history, look at the plain CT scan and look at the CTA in order to properly interpret the CTP.
All right.
So I think these are important.
I think, I hope by all of you listening to this module, I think we've given you a flavor of interpretation of CTP. I'm sure that, this is not end on or it's a comprehensive training module, but this is just to start thinking about using CTP in your daily practice. I think we've given you some real life cases. We've given you some challenging cases. We've given you, sometimes most of the cases are straightforward, where you got a good history, you got a good CT angio and a CT perfusion, and you make a decision. And sometimes decision making can be difficult, challenging, and that's a place where you need to have a holistic approach, debate, and make the sort of a right decision. And again, it is very important that whatever we are using through Rapid AI is to enhance your decision making, and you can't just make a decision just based on AI. You need to really make a decision taking the history, the patient in your center, the CT angio, and discuss if you have any sort of decision making difficulties. So I'll just last few words from Maha on.
I think I have just one last comment, which is actually, unfortunately, it is common in some clinician practice. Substitution of the CTP for giving a definite diagnosis of a stroke. What do you think about this? This is very important. Some clinicians, after doing CTP and after having normal CTP, they just declare that this patient definitely does not have a stroke, which is I find difficult.
Yeah. So I think this brings to an important discussion.
Yeah, that I think this gives us an important last note. What do you think about this?
Right. Can you just take us through that?
Yeah. So it is very important, and it is sometimes in some clinicians' practice, whenever they do a plain a CTP, and the CTP comes negative.
There is no core, no penumbra.
Yeah, no core, no penumbra, no anything. They just declare that this patient
has not had a stroke,
does not have a stroke, and just discharge from our care, etc. I think this is
it's quite a dangerous practice.
Dangerous and difficult. So I just need everybody to understand this important information, which is most CTP protocols are centered upon the basal ganglia and supraganglionic level. This means that CTP will exclude large volume of the brain. For example, the posterior fossa and the superior cerebral hemisphere. Because of that, some infarcts can be missed in the CTP. Thus, normal CTP does not always indicate absence of infarction.
I think
this is very important.
A very important point. Yes, I think again, I think from medical school days we are taught that stroke is a clinical diagnosis, and imaging just aids in diagnosis. So there are instances where we have treated patients where we had a clinical evidence of stroke in spite of negative imaging.
Yeah, and they can still have MRI as a modality to
confirm
the infarct, not just saying
not
that this is not a stroke and that's
so
it.
that's very important. So again, treat your patients, not the scans, is the message. CTP is just an aid to diagnosis. It's not end all to make a diagnosis of stroke. Stroke is still a clinical diagnosis. So we need to make sure that you have to understand that if just CTP is completely normal, it doesn't take away your clinical interpretation. So you, or if you still have a patient with the clinical signs of stroke, like a posterior circulation stroke, and if you feel they're within for window for lysis, you still have to treat the patient as a
and you
stroke.
Can consider brain MRI as well
as a modality to look for more evidence. Maha, thank you very much for your time.
Thank you.
And I hope the listeners have taken some important learning points, and we would appreciate some feedback. This is our first attempt in reaching out to all the frontline clinicians who are interpreting brain imaging and part of decision making. So we just want to hear some feedback to see how we can improve this course in the future. So feedback is going to be paramount, and we look forward for hearing from you for future courses. Thanks for your attention.
Thank you. It's been a pleasure to have this discussion with you. Thank you.